Hello, I'm Dr. Prathima Reddy, the Director and Lead Consultant at SPARSH Hospital for Women and Children, Bengaluru. So I would like to talk about the maternal mortality rate in India. What is interesting and good news for the women in this country is that it has been steadily declining over the last few years. And the government and the partnerships between the public and private hospitals have made great progress in bringing this down to currently 113 per 100,000 women. Now, for those of you who don't know what maternal mortality is, it's basically a representation of how many women who are pregnant and after pregnancy die during pregnancy, childbirth and beyond that. So this is a direct indicator of how good the services for pregnant women are in this country. Contrast this with the developed world, where the maternal mortality can be as low as 9 to 15 per 100,000. One of the main reasons that women die in this country is postpartum hemorrhage or bleeding post-delivery. And this is something that has been a nightmare for us obstetricians over the years, where a woman can bleed to death in front of our eyes. But as I said, the country has made progress. This rate is declining, although we still have a way to go. The quality of care, as can be imagined in a country as diverse as India, varies. It varies from hospital to hospital within a city. It also varies from hospital to hospital between the urban and the rural areas in this country. There are places in this country where a woman can get no medical care or just bare enough medical care, which may or may not help her survive and go through the pregnancy and delivery adequately. One of the reasons why women die in pregnancy and childbirth is because of inadequate blood, inadequate facilities in a healthcare or a hospital, and inadequately trained healthcare personnel to take care of her. So this divide, I hope, will be brought together at some point in time over the years in order that the maternal mortality is reduced and also the healthcare that women receive is of a better quality. In recent years, there's been a lot of talk about evidence-based medicine, practicing evidence-based medicine, and having protocols for the delivery of healthcare. Now, this is extremely important, and I was first exposed to this when I went to the UK to do my training, from where I have got my MRCOG, which is the membership of the Royal College of Obstetricians and Gynecologists, and also the fellowship of the same college. Now, the difference that I noticed between the two countries was that there, everything had a pattern. So much so that if you moved from one hospital to another, you would be able to cope with the next hospital straight away without much looking over to get help from somebody else. And this is because women and men in the other specialties would be given care according to protocols set nationally. So there was no dilution in the care that people got. Now, this is something that when I came back to this country some years ago, I noticed did not exist in a big way. However, I'm happy to say that over the years, the doctors and especially the gynecologists in this country have gotten together under the aegis of FOGSI, which is the Federation of Obstetricians and Gynecologists in the country, and also the local societies have made protocols, have made guidelines, so much so that obstetricians and gynecologists can now look to these in order to be guided as to how to manage cases. This also helps us to come together to be able to discuss cases under the same umbrella so that most of us are treating and looking after women in similar ways. So the difference that basically gives the West an edge over us is their adherence to evidence-based protocols and evidence-based medicine. And medico-legally, this will stand us in good stead if we were to have a problem, because then in a court of law, if you can justify what you did by saying this is what is practiced both nationally and internationally, that would help save the day. We at SPARSH have always believed that medicine is not just a science, but an art as well. In fact, many times it's probably more of an art than it is a science, because ultimately medicine is all about listening and communicating. They say that you can listen a soul into existence, And I have found this to be so true in all my years of being a doctor. As you grow older, you realize that you can actually just listen to a person's disease and make them feel better just by listening. And I've had people coming up to me and saying, "Doctor, thank you so much for listening. I know we can't do anything about this disease, but at least you listened and nobody else listened." So I think it's very, very important to make sure that we are treating this woman holistically, looking into everything and not just physically and giving out, say, tablets or prescriptions. And this is something that we firmly believe in. And we make sure that every single person who works in this hospital is attuned to this thought process and is also tutored about this so that they are sensitized to the needs of people, whether they're in pain or in labor or have cancer or any other problem that they come to us with. The way we go about doing this is making sure that we have regular training programs for all our healthcare workers, starting right from myself down to whoever needs to be taught this in the whole system. And there are protocols, there are procedures, there are policies put into place in order that every single person attends these classes, not just attends them, but is also evaluated on how they're doing. And we ask for patients' feedback. We also watch them, and they may not realize that we are watching them, and constantly give them or their superiors feedback. And with regard to medical protocols, we have very robust protocols in place to deal with women with all sorts of problems, whether it is pregnancy or gynecology. And this makes it very easy for our doctors and our nurses to be able to deal with problems on a very scientific level and to be able to follow the same guidelines all the time for similar problems. For example, if a woman were to come in with, say, pain abdomen, we know the nurse is the first one who sees her in the emergency room. She does a few routine things for her. She's taught what she's supposed to do, what she's supposed to ask the patient, the clinical signs and symptoms she's supposed to look out for, examine, and inform the doctor. And so on and so forth until they finally get to the most senior doctor to inform them about the problem that she's undergoing or the problem that they need to treat.